I recently went to the emergency room in the United States. Don't worry, I'm totally fine. That's not what this video is about. Instead, the story is about what happened 2 months later when I received 3 bills in the mail. One was for the emergency room services, including the time I spent in triage, taking my vitals, and an EKG that was conducted. The second was from the lab, who tested my blood work. And the third was from the nurse, who attended to me at my bedside. Pause. Let me be more clear. This was not a bill from the hospital. I didn't know it at the time. It was never disclosed to me, but that nurse was an independent contractor, not an employee of the hospital, who subsequently billed me directly for her time, which, by the way, cost just as much as the emergency room visit itself. This bill and the entire experience led me down a rabbit hole where I discovered how these kinds of contractors are not only becoming the norm in US emergency departments, but how they significantly increase the cost of your healthcare bill. And they might just be on their way to European hospitals as well. So, let's take a look.
It seems like to me one of the big problems we have in our health system today in the United States is we've got a lot of companies and corporations who are rapidly consolidating, and they're strip mining the American health system for their profits, but not for the good of patients.
Yep, that's me. You're probably wondering how I ended up in this situation.
Okay, sorry, I had to poke a little bit of fun at myself here. It is worth telling a short story of how I ended up in a US emergency room in the first place and why I received these bills. For those of you who don't know me, and this is the first time you are watching one of my videos, I'm an American who has been living and working in Germany since 2018. As such, I no longer have US health insurance. I have German public health insurance and, thankfully, travel health insurance, but I'll get to that in a little bit later. The health episode that I experienced isn't really a dramatic story. Basically, I was experiencing numbness on the flight from Zurich to Chicago. It started in my hands and my feet and slowly crept up my limbs and into my face. Now, I could still walk, talk, eat. I wasn't slurring my speech. But the neuropathy wasn't going away after I disembarked. So I made the decision to drop my kids off with their grandparents and then head to the local hospital to get checked out. Obviously, I didn't want to be going into some kind of invasive fact-finding mission while I'm in the United States. I am acutely aware of how expensive US healthcare is, and ideally, if we're going to start a bunch of tests, I would prefer to do that in Germany where it's 100% covered and be under the care and supervision of my physician. But obviously, being numb isn't a good thing, and I felt that it was important to rule out that I wasn't having some kind of a medical emergency. Now, all in all, I was there for about 5 hours in total. I think I even took a nap in the ER room because, again, I was fresh off of this transatlantic flight, and it was like 4 a.m. German time by the time I got out of there. But while I was there, they took all of my vitals, did some blood work, a urine sample to send off to the lab, and they did do an EKG. But basically, I got the answer of, we don't really know what's wrong with you, but all of the critical markers are totally fine, so it's probably okay if you just go ahead and go home. The only thing that I did find to be curious was that I never once actually spoke to a doctor while I was there. In fact, the entire time I was in the ER, only 2 people ever came into my room. One was a student nurse who was the one to take my blood pressure and blood samples. And the second was an APRN, or an advanced practice registered nurse, who did my intake, ordered the EKG and blood work, and looked at my results and then discharged me. And please note, I am not dismissing the role or the expertise of this care provider by saying she wasn't a doctor. I am specifically not going to be disclosing her name. I'm not trying to place any blame on her, but it is very relevant to this story and what happens afterwards, that despite the neurological symptoms I was displaying, a physician never stepped foot in my room. But nonetheless, I still left the ER satisfied that at bare minimum, this was not critical, and I could make the journey back to Germany to do a follow-up, and I expected to receive a bill in the mail for the services provided. Which, speaking of, let's talk about those bills. The way that my foreign travel health insurance policy generally works is that I pay for the medical bills up front and then submit my receipts afterwards to be reimbursed. So this means that from the hospital's point of view, they bill me like they would bill anyone else without health insurance. In their eyes, I'm a self-paying, out-of-pocket customer. And this is where things get really weird and complicated if you are not from the United States. In the US, the amount you pay for any procedure, test, or service is kind of like that show, Whose Line Is It Anyway?
Welcome to Whose Line Is It Anyway, the show where everything's made up and the points don't matter.
All hospitals have an internal price list for every medical service, medication, and supply provided. These gross charges are often significantly higher than the actual costs or negotiated insurance rates designed to maximize revenue from various payers. Final payments are then heavily adjusted based on contracts with insurers or government rates like Medicare and Medicaid. But for me specifically, the total before discounts of the services from the hospital directly came out to just shy of $4,400. This includes about $500 for an EKG, almost $2,000 just to take up a bed and breathe the air in the ER department for 5 hours, another roughly $1,900 for lab services, $30 for a pharmacy fee, even though I was never administered any medications, and $56 in professional fees, which I presume is to cover the cost of the registration and billing services. At the end, I was given a self-pay discount, which massively decreased my final bill. Just a quick note here, I did not call and haggle or negotiate that discount. This was just the final bill I received, and although I am very thankful to not have been charged that original amount, I'm also not going to be naive and think that the hospital was just being nice by taking 72% off of the original bill. Numerous studies have documented that uninsured patients and those who pay with their own funds are charged 2.5 times more for hospital care than those covered by health insurance. So those charges are already massively inflated. And despite the discounts, the hospital still makes a profit on uninsured and self-pay patients. But like I said at the start of this video, this wasn't the only bill I received. The second bill was from the private lab who ran my blood work. Yes, despite being charged almost $1,900 for laboratory fees from the hospital, I still had to pay the private lab $85.50. Which, to be honest, is still way cheaper than I was anticipating. This, to me, doesn't seem all that outrageous. But what did take me by surprise was when a third bill showed up in my mailbox a couple weeks later, asking for an additional $1,224. I was confused, to say the least, and I actually called the hospital's billing services department directly and asked, was this some kind of scam? What was going on here? Turns out, no, this is a legitimate bill that I still needed to pay. As the hospital billing services department informed me, the provider, the APRN who I saw in the emergency room, was not a hospital employee, but instead a third-party contractor who, again, nonetheless bills me directly for an, quote, emergency department visit with a high MDM, which I found out later is their billing code for high medical decision making, indicating a severe, life-threatening, or high-risk condition requiring extensive data review and urgent management, signaling that my illness posed a, quote, significant threat to life or bodily function.
Well, I've been thinking about it, and I think it's the right thing to do.
The APRN was a very nice person, but she was at my bedside for maybe 7 minutes total. Of course, she still had to take the time to order the tests, look at the results, and I am very thankful for that. But I don't understand how you bill someone for a high medical decision-making, severe life-threatening condition, but an MD never steps foot in the room? I certainly hope that a physician looked at my charts and provided guidance behind the scenes, but they never evaluated me, spoke to me, or gave any indication that what I was experiencing was life-threatening. I'm not mad about that. This is a triage area and the docs have way bigger fish to fry. I was taking a nap while the lab ran the test results. But why are you billing me like this is a life or death situation? Well, as I did my research and quickly found out, this happens all the time. And in fact, it's becoming the norm. Hospitals have long embraced the practice of outsourcing some services to specialized companies, especially for non-clinical tasks like laundry, information technology, and cybersecurity to boost efficiency and quality. However, over the past few decades, there has been a fast-growing trend of hospitals outsourcing clinically relevant services like anesthesiology and emergency medicine to companies separate from the hospital. According to reporting, currently 2/3 of U.S. emergency departments use some sort of outsourcing, and more than half of practicing emergency physicians work not for the hospital, but for separate companies called contract management groups, just like the APRN that treated me. Since the 1990s, these contract management groups, I'm going to be calling them CMGs from this point forward, have increasingly taken control of staffing hospitals. CMGs originated in doctor-owned companies trying to address a legitimate issue, the headache of ensuring that hospitals are properly staffed 24/7. Now, there is no question that emergency rooms around the US are stressed. And certainly, contracting out physician, nursing, and clinical services can, and often are, viewed widely today as an essential tool to address fluctuating patient volumes and to manage the high financial and administrative burdens of staffing a 24/7 department. However, there are notable skeptics on the negative effects of outsourcing clinically relevant professions like doctors and nurses. In a report published by the Mayo Clinic in 2021, their findings state unequivocally that aside from the high risks of loss of control over clinical quality and from errors and potential harm to patients, outsourcing may not provide the anticipated financial benefits over time, especially when discounted pricing is used to secure an outsourcing contract with the intention to raise prices later. Furthermore, given that physician groups not employed by a hospital can opt out of the hospital's insurance contracts and charge pretty much what they wish, outsourcing to an out-of-network physician group often results in higher charges to insurers and patients, sometimes adding up to thousands of dollars per clinical encounter. And yeah, this tracks exactly with my firsthand experience. In a study of nationally representative data from the Medical Expenditure Panel Survey for 2001 to 2016, privately insured or self-pay patients receiving an out-of-network bill for emergency care were charged an average of 10 times more than other emergency patients, which means that sick patients who go to an in-network hospital are likely to be completely unaware when they receive care from an out-of-network provider, which may stun them and their families when they face medical charges that they assumed their insurance was going to cover. But changes in hospital regulations, including how patients are billed and the increasing cost of premiums, is surprisingly a topic that often flies under the radar. That's right, despite having a huge impact on family finances, many news organizations just simply don't bring it up. And when they do, they're often heavy on the partisan spin and light on the details. That's why I always use our sponsor, Ground News, because it gives me an easy, data-driven, and objective way to read the news. On Ground News, every story comes with a quick visual breakdown of political bias, factuality, and the ownership of sources reporting, all backed by ratings from 3 independent news monitoring organizations. And recent developments on a proposed overhaul to the German healthcare system serves as an excellent example on how contentious cost capping measures are for service providers, politicians, and patients alike. For example, this recent story on the German Health Finance Commissioner's 66-point plan to lower rising health insurance contributions as the system faces a potential 14 billion euro deficit by 2027 was covered by over 40 news outlets. And I've been using their new comparison feature to see specific differences in left and right reporting. For this story, a left-leaning outlet highlighted that the proposed changes amounts to a, quote, open declaration of war on the working class, end quote, accusing the media of downplaying the explosiveness of this healthcare reform on everyday working citizens, while a right-leaning outlet highlights other facets of the plan, including a so-called sin tax on tobacco and alcohol, which would fund the healthcare system too. If one side of the political spectrum is ignoring a story, the blind spot feed will let you know so that you can make up your own mind on how reliable the reporting is, which is a level of transparency that I very much appreciate when I am sifting through the data and reports on every subject I cover right here on my channel. So go head over to ground.news/Ashton to check it out, or click the link down below in the description of this video. You can subscribe through my link to get 40% off the Vantage subscription, which includes unlimited access to all their amazing features. Plus, when you subscribe, you not only support me, but you're also supporting an independent platform trying to make the news more transparent. But the elephant in the room for emergency medicine and other medical specialties is that a profit-maximizing goal can conflict with prioritizing the well-being of patients and medical staff, especially when private equity gets involved. And boy, do they ever. Private equity companies pool money from wealthy investors to buy their way into various industries, often slashing spending and seeking to flip businesses in 3 to 7 years. While this business model is a proven moneymaker on Wall Street, it raises concerns in healthcare, where critics worry that the pressure to turn big profits will influence life or death decisions that were once solely left to medical professionals. Nearly $1 trillion in private equity funds have gone into almost 8,000 healthcare transactions over the past decade, including buying into medical staffing companies that many hospitals hire to manage their emergency departments. Today, there are 2 firms that dominate the ER staffing industry. One is Team Health, who was bought by the private equity firm Blackstone in 2016. And the second is Envision Healthcare, bought by KKR in 2018. According to research conducted by Texas A&M University, in emergency care, for example, these contracting groups often have aggressive patient-per-hour quotas and provide incentives to medical staff to order more procedures and tests, even if they're not warranted. In one study, more than 1/3 of emergency physicians employed by these groups said that they had concerns about losing their job if they raised questions about over-testing, quality of care, or patient treatment, roughly double the rate for doctors employed by hospitals. And contract management groups have also contributed to surprise billing and excessive collections. For example, in the first 6 months of 2019, Team Health, again, one of the largest such groups in the US that contracts out emergency room physicians, owned by Blackstone, filed more unpaid bill lawsuits against patients in Memphis, Tennessee than 3 local hospitals did combined. It was only negative publicity that made the company reverse course and stop suing patients. But in addition to overtesting and excessive collections, to boost profits, what has also happened in lockstep is that emergency rooms staffed by private equity CMGs are increasingly relying on nurses and physician assistants instead of doctors, which is also what I experienced firsthand. As this third-party staffing strategy has permeated hospitals and particularly emergency rooms, they have also sought to reduce their top expense, physician labor. Contract management groups employs fewer doctors in its emergency rooms as one of its cost-saving initiatives to increase earnings. So yeah, it's a pretty simple equation when you think about it. Their number one expense is the board-certified emergency physician. So they're gonna want to keep that expense as low as possible. Federal data shows us that emergency medicine doctors are paid about $310,000 a year on average, while nurse practitioners and physician assistants earn less than $120,000. Generally, hospitals can bill care by a mid-level practitioner at 85% the rate of a doctor while paying them less than half as much. Private equity can and does make millions off of this gap. For example, Envision once encouraged ERs to employ the, quote, least expensive resource, end quote, and treat up to 35% of patients with mid-level practitioners, according to a 2017 PowerPoint presentation. Critics of this strategy say that the quest to save money results in treatment meted out by someone with far less training than a physician, leaving patients vulnerable to misdiagnosis, higher medical bills, and inadequate care. And these fears are bolstered by evidence that suggests that dropping doctors from ERs may not be good for patients either. According to a working paper in October by the National Bureau of Economic Research, who analyzed roughly 1.1 million visits to 44 emergency rooms through the Veterans Health Administration, where nurse practitioners can treat patients without oversight from doctors. Those researchers found that treatment by a nurse practitioner resulted, on average, in 7% increase of cost of care and an 11% increase in length of stay, extending patients' time in the ER by minutes for minor visits and hours for longer ones. Now, I want to be fair here because nurse practitioners have a vital role in the US healthcare system, and it would quite literally not be able to function without them. After all, the US has fewer physicians per capita than most peer nations. However, this actually isn't necessarily an issue for emergency rooms. NPs are not being necessarily hired there to fill a staffing void, unless you're in a rural area. There are exceptions to this rule. But on the whole, the United States is facing a projected surplus of board-certified emergency medicine physicians, with estimates predicting an oversupply of nearly 8,000 to 10,000 emergency physicians by 2030. So please do not mistake me. Nursing is an incredible profession and an essential part of hospital staff. And increasing overall clinicians in a hospital setting can certainly help with efficiency, moving more people through the ER more quickly. But we should be very careful of private equity-owned organizations that are hiring NPs and PAs in lieu of MDs. There is a reason why there is a distinction between nurses and physicians. There's a difference of training requirements, a difference of educational rigor, a difference of expertise and certification that matters. And I don't think that's a controversial take. While these professionals do highly skilled work in a variety of clinical settings, the emergency department is one place where care outcomes are more likely to suffer if a doctor isn't involved. After all, the emergency department, the front door of the hospital, is the critical staging area for severely ill patients and plays a key role in half of hospital admissions. Speed and accuracy in triaging and stabilizing a patient can dictate a prognosis. So if you're not from the United States, but have made it this far in the video, you are probably wondering, how global is this trend? Well, across the world, populations are facing challenges in accessing healthcare, along with a healthcare workforce that is often insufficient or poorly distributed in relation to their needs. And in most OECD nations, the development of advanced nursing practice appears to be a strategic response to improve access, quality, and continuity of care, while optimizing human resources in health. However, how these roles function, what kind of responsibilities they have, how much they can charge, and how they are contracted to work within their respective medical systems is significantly different from the United States. Even in the United Kingdom, which has had nurse practitioners for 40-ish years, their role is still heavily focused on minor injuries and illnesses like sprains, lacerations, and burns, rather than complex multi-system critical care. And again, I know I'm painting with a very broad brushstroke here, but emergency care, by and large, remains firmly under the responsibility of hospital-based physicians and specialists in most OECD countries. Now again, breaking down every single healthcare system, especially at the end of an already very long video, is not going to be possible today. But the biggest difference is that, at least for now, the key focus for private equity firms in countries with robust public healthcare systems have been the outpatient medical market. Specifically, we most often see them in specialized clinics like dental care, ophthalmology, diagnostics, and radiotherapy. And in these spaces, private equity-backed hospitals do have some hallmarks of the US system, often experiencing significant cost-cutting measures, reductions in administrative staff, and in some cases, clinical staff too. The closure and/or consolidation of rural hospitals in favor of private outpatient specialist clinics is not a uniquely American phenomenon. But what is uniquely American is that doctors in Europe, and really any medical professional, can't just bill whatever they want for a medical service. Okay, again, never say never, but the vast majority of physicians operating within European public healthcare schemes, including social health insurance and national health service systems, charge within a predetermined, negotiated, or fixed schedule of fees. Here in Germany, for example, statutory insurers pay fixed rates, and even private patients are still billed according to a set schedule of fees, which, yes, allows fees to vary between 1 to 3.5 times the standard rate depending on difficulty, but it is still nonetheless a standardized rate. But there is no single mandatory standard rate for billing for medical services in the United States. And the kind of charge as much as we can get away with system that currently exists feels extraordinarily exploitive. When I turned in my bills to Allianz, the agent who processed my claim was just simply flabbergasted. Like, what do you mean you went to the ER and you didn't see a doctor? The nurse who you saw at the hospital doesn't work for the hospital? And she charged you how much? For what exactly? Same girl. Yeah, same. Now, but I would love to know how you would have reacted to such a situation, so let me know down in the comments below. And as always, if you enjoyed what you saw today, be sure to hit that thumbs up button. And for more content from Type Ashton, hit that subscribe button. So, I'll see you in the next video. Cheers!